Okay guys, so I'm going to be demonstrating some x-ray positions here, which is a commonly asked question that we get. And I'm just going to be going through some standard positioning techniques because they do vary for each awarding organisation. So please do check your AO for any specifics to your scenario, such as if you've got a fracture or something else, you might, it's probably considered better to not over manipulate the leg, over extend, over sandbag, etc., things like that, because you could be causing them pain. So just pay particular attention to what your scenario is, your left, your right, your V's, your D's, your DV's. Pay extra attention, but for the purpose of today I've got a couple of positions that I'm just going to show you throughout this video selection. So I'm going to start by obviously saying that depending on your awarding organisation, you may or may not need to get a plate, you may or may not need to select a grid, and you may or may not need to collimate to the plate. I'm going to do it as if we are collimating to the plate. If you do not need that step, you can go ahead and skip this step. Again, it does vary depending on each AO. And we're going to do a right lateral thoracic view to start. So for this one, based on this dog, I would, because it is a teddy, I would pick a medium-sized plate. Medium or large would be fine. And because it is the thorax and he would be over 10 centimetres, I would also select a grid. The lineup for a grid is over 10 centimetres, not 10 kilos, not 15 kilos, and these are the numbers. 10 centimetres is the golden rule. I'm then going to just turn the light up quick and collimate to the plate, because that's when I'll know that I've positioned my x-ray all okay, and I'll know that it's all in my field of view correctly if I collimate to my plate first. So I'm going to put my light back on. I would ask my examiner to help me move my patient, paying particular attention to the head. Personally, if I was a student, I'd rather support the head and have someone else support the body. So I'm going to take it as if I am supporting the head and they're helping me lift them into a right lateral recumbency. But again, you would ask for restraint for that purposes, and you want to consider always being really gentle to the head here. Now, this scenario may be under sedation or GA. It can vary. If it's under GA, then you can use tags, so like ties, and you can use tape, although that's not really needed for a thoracic view. If it's under sedation, you cannot use those. To be honest, you don't need those for a thoracic view anyway, so don't worry. But one of the biggest differences is about how much we support / wedge the body. So if they're under sedation only, you must secure both ends of the patient. Now, most thoracic views are under GA as a scenario, because obviously that would be better. But if you do have a sedated version, you will need to wedge both sides of the patient, so you make sure that they're stable. Again, I'll demonstrate it as if they are sedated, so we know what we're doing. So one of my first things I do is pop my right-left marker, and I know it's in my field of view because I've already collimated to my plate, and I make sure that I just check with my examiner, and I'm happy that I've put him on the plate enough, which I haven't, so I would say to the examiner, we just need to put him a little bit further back, and again, I'm always securing my head and airway, that's more important. You'll notice here I wanted the thoracic inlet on the plate, so I've moved him back so my thoracic inlet is in my field of view, and actually this is going to finish just past where last rib would be. Last rib on him would be about here. One of the biggest reasons for students struggling with x-rays is that you don't think about the actual position of your dog and the size of your stuffed toy. In reality, your stuffed toy is a lot smaller than a real patient, so you need to collimate smaller, because you need to show any assessor that you actually understand where those landmarks would be on any patient whatsoever. So I'm going to pull my forelimbs forward, high limbs back, but don't worry too much about that. If you wanted to put a wedge underneath the thorax to prevent rolling, then you can, but that's really it for wedging. The rest now we're going to do is secure in place. So some of you may have been taught one sandbag per limb. To be honest, it depends on the amount of kit you have. The main thing is just making sure they're secure. And as you'll notice there, what I did was I've made the sandbag thin over the part that I'm actually going to put over the head, because I don't want that putting pressure on his airway if we're assuming that he's sedated, and I have to do so. And I'm keeping it like towards the top of the head where the skull would be, but not heavily enough over the neck that I'm going to actually cause him any major pressure, bless him. I want him to be able to breathe. Again, just going to support the legs, and then because we're assuming he's sedated, I'm going to put one over my hind legs as well. So I've prevented rotation, I've made sure that my airway is safe, I've asked for restraint, I've collimated to my plate, I've popped my right-left marker. I'm happy with this, so what I'm now going to do is just show you what this would look like with light. So For my light and my collimation, now this is a bit annoying because where I've collimated out actually isn't where he is. So I'd probably go to there, because if I come in any shorter, you'll notice I start to cut off too much. I need that thoracic inlet, so that's probably about as far as I can go on there, but I'm going to come in to the lateral skin edges. And I have got thoracic inlet, I'm probably just a little bit past the last rib based on this light, and that's okay, that does happen sometimes. So I would centre over the mid-thorax, I would collimate to include the thoracic inlet, the last rib, and our dorsal ventral skin edges, and that would be for a right lat radiograph of the thorax.